okay, we'll go fast with history and all that because he was the first guy who diagnosed, who wrote about the stroke. And he described not only the paralysis and the aphasia, but also the place where was you see the internal carotid artery as the source. This is Gasmonis, the guy who did the first angiogram. Okay, so we have two different pathways. One is necrosis, that is the core of the infarct, and the second is apoptosis, the pathophysiology in the penumbra. So the penumbra can be recovered because you have to stop the process of apoptosis. Apoptosis is when you have a release of glutamate. When at the start of the stroke, there is a release of glutamate. The glutamate releases calcium. The calcium goes to the mitochondria and starts the process of destroying the cell. So you have to give the flow again to stop the apoptosis. The necrosis is already there. You know, the portion of brain that is already dead from the beginning. And these are the, okay. In general, you have major infarcts that you see is 25 to 35%. You have lacunar, and most of them are minor infarcts. That is what we see every day. So obstruction of large vessels is the less common. It's 25 to 35%. Okay, so they say, okay, time is brain, but this is not really the thing. The time plus collaterals are brain. So we have to check parenchyma about the extent of the infarction in the core of the stroke, to check the pipes, if there is clot, CTA or MRA to study, perfusion, status and severity of the perfusion in the penumbra. Okay, you know CT and MR, CT. Generally, the CT is used as the first tool to rule out hemorrhage. So we know that this is not really true because this is the same patient. And you see that this patient has all these hemorrhages, and the CT is not seen. So CT sensitivity for infarcts, if it's blinded, 38%. If you know the history and you are looking for an infarct, 52%. Normal Hounsfield units in the gray matter is 30 to 35 Hounsfield, and white matter is 20 to 25 Hounsfield. So you have to put level and window settings in window 30 and level 36 to really see the infarct. The change in attenuation is because there is 1% increase in water, that increases attenuation in 3.5. So that is 2.5 Hounsfield units. In the acute infarct, in the less than 30 minutes, there is a failure of ion channels due to inadequate ATP. So there is cytotoxic edema. The sodium and potassium pumping is not working. More than 3 to 6 hours, vasogenic edema. And 2 to 6 weeks after the infarct, this is a fogging effect due to resolution of edema and infiltrate of macrophages and neocapillary. So in 2 to 6 weeks, the area tends to be more dense. The aspects is a score that was started in Alberta, Canada. That's why it's called Alberta. There are 10 regions, that is easier to see here. The normal score is 10 points, and a score of 7 has been correlated with infarct involving 1/3 of the MCA territory. So these are the territories for the aspect. So in every area of hypodensity, you decrease one number. So it's 10. If you have these 3 areas with hypodensity, you say, okay, this is a 7. The problem is, you know that these patients, in the majority are patients with microvascular disease. So it's very difficult to determine if this score. The early signs of infarction in CT, everybody knows. One is the hyperdense sign. If the hyperdense sign is more than 8 millimeters, the therapy, the intravenous TPA, will be ineffective. This clot in the MCA that producing this hyperdensity is the indication for thrombectomy. So the minor infarcts, you will have intravenous TPA, but the major branch occlusion, this is the patients that most are benefited from the treatment, you know. So, yes, the length. If the length is more than 8 millimeters, this is a big thrombus. So it's more difficult to retrieve with the Mercy or some other method of retrieval. Now, in general, in all places, they are using retrieval, not injection of TPA in the site, intraarterial. So, because this is producing less hemorrhages post-retrieval, you know, and it's more effective. So, the other one is the effacement of the putamen, you know, and you see kind of a blur area here. You also see that there is no loss of the soul side. You see, compare this side with this side. So we are suspecting that this is an infarct in the territory of the right MCA with a thrombus in the MCA. And this is 24 hours follow-up in this patient that was not treated, and so we had it. If you see this in the posterior circulation, you see it's the same thing. This is the PCA, and again, 6 days after, you have the infarction already there. In this case, you have a really beautiful hyperdensity in the middle cerebral artery. This patient had more than 4, it was like 6 hours after the stroke. So it was contraindicated according to the rules, and this was the mother of a secretary of this department. So Dr. Schoenholz at that time was the interventional neuroradiologist, decided to treat the patient. And so, and this is the sign. You see that the effacement here of the external capsule, you see. In here you can see an internal, and here is the blur. This was the initial with the occlusion of the MCA practically from the start. This is the result. And the patient was aphasic and hemiplegic, and completely recovered. The Dr. Schoenholz got a quality, I think had a 4, because the patient had hair loss because of the radiation in that. we can see in the standard slices, you see when there is an ulcer and when there is a soft plaque. These are the most dangerous abnormalities or lesions in the wall of the artery. You see the ulcer, but most the soft plaque that is the one who gives the emboli and sends to the circulation. This is the same thing, but in 3D in the 3D reconstruction. Here you have calcification, you have the soft plaque, and the narrowing of the internal carotid artery at bifurcation. In general, the standard, CT, the MIP reconstruction is better than the 3D. It's more difficult to recognize the lesion in the 3D than in this. And also, you have the advantage that the software gives you the degree of obstruction. Again, ulcerated plaque and the soft plaque. Now we go to CT perfusion. It's based on the analysis of the curve of injection of some contrast. It can be with the CT, injecting iodine, or can be with the MAR, giving gadolinium. When this is the first derivative of this curve, the area from the starting of the curve to the peak of the derivative is the arterial portion. The area between the maximum and minimum of the derivative is the mean transit time. And from the end of the derivative, the minimum of the derivative to the end of the curve is the venous time. And so they compared xenon with the injection of contrast and demonstrated that the CT perfusion has a lot of disadvantages and errors. So CT perfusion has low reproducibility. Why? There are a lot of factors that one is the injection, how you inject, the time you acquire, the cardiac output of the patient, so everything contributes that the measurement in CT perfusion is not really so accurate. We developed the CT perfusion here with Desiree and Angela. And this is how you do. You select these regions. At this level, in the basal ganglia, you have anterior circulation, you have the MCA, and you have the PCA. And you will get the curves. The CT will give you cerebral blood flow expressed in cc's, 100 grams per minute. Generally, there is a decrease in the infarct curve. The cerebral blood volume is expressed in cc's by 100 grams. And this is the most used to check the core. The CBB is decreased in the core. And the MTT, that is the mean transit time, is the penumbra. So you will have a decreased CBB in one area and surrounded by MTT, that is the penumbra. So this is the mismatch. There is also this K-trans, or permeability surface, is the permeability of the blood-brain barrier. If the permeability is high, you have most probability to have a hemorrhagic transformation. So this is how the parameters in perfusion vary, but you have, when there is a decrease in this of the volume and increasing the area of MTT, this is the parameter we use to do the middle cerebral artery occlusion. Usually it causes substantial decreases in local cerebral blood flow. Local cerebral blood flow appears defined threshold for paralysis and infarction. When local blood flow drops from 23, irreversible paralysis occurs. When local flow fell below 10 to 12 or below 17 during permanent occlusion, irreversible local damage was observed. And so we have, you see, two different things. One is the reversible paralysis, and the second is the irreversible local damage. Both will have the same expression in the cerebral blood flow. So the perfusion image theoretically cannot be used to find ischemic score. You see that the paralysis, you have infarction or you have the paralysis that is recoverable. And so they have the same amount of flow, cerebral blood flow decay. So in the infarct core, there is a reduced blood volume. The infarct penumbra has increased mean transit time. And we have an example. There is a narrowing of the MCA. This is in the 3D. And you have here the perfusion. These are the curves. This is the normal side, and this is the side of the occlusion. And here you have the cerebral flow, volume, mean transit time, and K-trans. In magnetic resonance, you can have a ultra-fast protocol because you do the DWI and it has 40 seconds, and the fast protocol that we have 40 seconds for DWI, 5 minutes for the susceptibility, 6 minutes for the angiogram, and 3 minutes for flare, and it takes 15 minutes.
So prefer the fast protocol?
The fast will be okay. Yeah. So everybody knows that you have the DWI. If you continue the DWI in your in the packs, you go ahead after the DWI, you will have the T2. So if you place a region of interest and divide the intensity here by the intensity here, it will give you exponential diffusion. If you take the logarithm, it will give you the ADC. The sensitivity of the DWI is 91 to 100%. The specificity 86 to 100%. And here, for example, we did the math and we have the numbers. Generally, the ADC from 0 to 3 hours is around this number and is increasing as we wait. Hyperacute 0.50, 0.30, acute 0.30, 0.50, subacute 0.50, 0.60, and chronic more than 1 because it's water. And so this is the infarct core is well represented by the acute diffusion lesion. And this is the infarct core and the penumbra. If you have a big penumbra, the infarct core will be small and the opposite. If you have a large core, the penumbra will be minimal. So the thing is, this the diffusion is class 1 level of evidence A. If the core, that is the DWI, is less than 70 cc's, there is good prognosis. And if the volume is more than 70 cc, the poor outcome. Why? Because it means that the collaterals are really good. And here we have some different cases. This is 1.7 cc, 5.2, 51, 0.03 cc's, this is 217, this one. You see that this patient is infant and there is no penumbra. And in this patient there is a huge penumbra. The thing is, all these patients with small infarcts, they, without any treatment, they go all in a good way. They recover perfectly. This will not increase in time. This is the Savers paper, and he calculated that a typical patient loses 1.9 million neurons each minute, in which stroke is not treated. This is not true, because you have the patients, different patients, some have total loss in the first hours, and these patients, they don't have any progression after 20 hours, 24 hours. You see? So it's not depending on time, it's depending on the collateral. This is the thing. The other thing, they did a study with thrombectomy, and the time from the initial time to the time it was treated, there was no difference in outcome. The diffuse 2 study suggests that the patient with mismatch and good collaterals can be treated beyond the 6 hours. On the other hand, a patient with good collaterals has decreased probability for the infarct to grow. Done and diffuse 3, that these are the last trials, have a window between 6 and 24 hours with good results. We studied how many patients diagnosed as a stroke were strokes. And so we have 10 had normal CT, is 9.26, 26.8 had normal CT but MRI evidence of chronic infarct or microvascular disease. MRI of evidence of other pathology, 50 of 108 patients had no magnetic resonance imaging evidence of acute stroke. So 46.3% of the patients diagnosed as a stroke were not. A large percentage, 46 of patients presenting clinical cells as compatible with acute ischemic stroke had normal brain MR or alternative pathology, and 3.7 of non-contrasted design were false positive for acute CVA. Okay, all these are. The flare, you can see blood, you can see hemorrhage, and also if you just divide the signal intensity in the infarct divided by the normal on the other side, more than 115 means that the infarct has more than 4 hours evolution. So theoretically it's not treatable. Again, the gradient echo or SWI, the SWAN, shows a lot of hemorrhage that the CT is not showing. This is a patient, the flare, a patient with microvascular disease, and this is the susceptibility image. You see that you don't see the hemorrhages even in flare. CT would be normal. In this case, you have the mismatch ADC and flare. It's less than 4.5 hours. And in this, you have more than 4.5 hours. You see? So, sir, you can treat up to 1.15. Okay, we have this case. You see this is difficult to do the aspect score because you have all these hypodensity areas. How you calculate this, you know? And the DWI in this patient is normal. This patient, almost the same image with infarct. And this is the defect in the MRI. In susceptibility, in some cases you see the thrombus. That's in this case. I show you this case that was done here, and the patient started at 8:45, was examined and scanned at 9:30, and you see this is infarct. There is an occlusion of the middle cerebral artery. You see the difference in the branches in the insula. There is no branches on this side, and you see the occlusion here of the artery. And they did thrombolysis. In this case, they didn't do the retrieval with mechanical. This is a case that recently, last week, showed Eduardo from Mass General. A patient, 49-year-old woman with sudden hemiplegia, a facial transatlantic flight. The lady was in a plane and started feeling first pain in the chest, and after that she developed aphasia and hemiplegia. So the plane landed in the Boston airport. They transferred the patient to the unit in the Massachusetts General Hospital. They did the CTA, and you see the occlusion. But after that, they do diffusion. Why? Because if the diffusion is less than 70, they treat, no matter the time. And so they treated, and the patient recovered. This is after. This is not in the paper, in the publication, but this I got from one of the authors. Okay, but you see minimal encephalomalacia, and the patient recovered. Some interventional neurointerventional radiologists, they do this, the parenchymogram, you see? So when they inject the contrast for the angiogram, they see how is the parenchyma doing. And you have here the normal side, and you have here the absence of collaterals here. They gave TPA, and so this side is feeling really normally. Oh my God. No. Okay, you have here the difference in the MR perfusion. I don't like too much the MR perfusion because it's not, they are only the MTT that you cannot see well, and you have this that is called positive perfusion. So it's not really an MTT, or in MR the parameters are different. So you only, we have this method, the OSL, that is the perfusion without injecting any contrast. And but it was cumbersome to do. We only had to only one slice, and we had to calculate ourselves. So we don't do anymore. Now the new machines, they have ASL in the protocol, but I don't know. You have an acute infarction, because there is increasing water, you will have increase in the E2 time. In some time, there is what is called a luxury perfusion, so there will be a small increase of collaterals around the infarct. Yeah, that you can see in the contrast. And this, you see the value of the ADC 0.22, for a normal of 0.68 on the other side. You see, so this is a hyperacute infarction. And this is the perfusion in ASL. Clinical case, 47-year-old, and so you have the CT in October, the CT in November. This is the T2 and flare, but finally you have an overinfarction in the same place. That is, of course, the infarction that repeats in the same area. And you don't see this with CT. No? And this is the perfusion. The perfusion was decreased in that area. And we don't use practically MRS. In MRS, there is an increase in glutamate, there is lactate in here, and the other peaks are normal or decreased. You see that the NAA is decreased because there is loss of neurons, and the choline and the minoxidil are almost normal. Remember that there are infarcts in the brainstem, you see. So sometimes they are missed because you look the infarct in the supratentorial compartment. In this case, a non-infarct with left paralysis and dizziness, and was a brainstem. The brainstem infarcts are very difficult to see, or you don't see in CT. The only way is to check MR. And you can also treat just beyond 4 hours or 6 hours. So the patients who benefit with treatment are the patients who had a major vessel occlusion, that is the carotid or the MCA, and they have less than 7 cc's of DWI. And what is the treatment? The treatment is mechanical treatment now. Everybody is doing mechanical treatment. If you don't have the possibility, you can do intraarterial TPA. And so CT showed infarcted area in early stage. Let's see, in 24 hours. No, the MR is the fastest. It's 20 minutes after the start of the occlusion. And I think that's it. We have some questions. You know how we are, the stroke protocols. When it started, you go to the CT room. First, they started doing an examination with NIH scale. But this increases the time from door to CT. So what they do, immediately they go to CT. So in CT, you check if there is hemorrhage. If there is no hemorrhage, you tell the neurologist, and this is the time you gave the report. And because they time this, And then you call operator and ask to dial 000, and so they know that the CT was done. And after that, they do the CT angio and the three-phase perfusion to see if there are collaterals. And this is our stroke protocol for now, If you have an acute stroke and you have the opportunity to go to the MR, just you have to tell the MR technologist that he has to stop the MR he's doing, and you put the patient. And this is the consensus now we had last week in the neuroradiology meeting. In some places, before scanning, they tell the patient, maybe we have to stop your study if there is an emergency, because they are doing a lot of stroke patients. But I don't think it's necessary. I think that if you explain to the patient, we have to do this because it was urgent, I don't think there is a problem. But for now, these are the minor, the less, because they don't send for MR unless they are in the floor and you have a consult, we have a patient with a possible stroke and you recommend to the MR. And so you have a diagnosis immediately. So this is the thing. I'm not pushing also very hardly to do MR because of this problem. We have both machines the whole day busy. We have to fight to bring the patient in the scanner. And so I think we need another MR in the emergency room. This is the solution. There is, I think Milwaukee, they have a truck with a CT machine. So the paramedics, they go with a CT machine, and if the patient, if they suspect a stroke, they do the CT perfusion. Also, there is a software that is called Rapid. And you inject the patient, and the software calculates the penumbra and the core and gives you the mismatch in green. And you can transfer this to your phone, to your iPhone. And because a guy from, he's in Dallas, Roy Riascos, in Houston. He's in Houston, and he had in his phone, and he received all the stroke patients and with Rapid, with this software. And you see the slice of the brain, the CT, with the green area that indicates the penumbra. I don't know. So this is, you have some questions about this?